Hi friends, this is Dr. Sarvajit Biligare. I'm a urologist with a keen interest in endoscopic enucleation of the prostate. Welcome to my YouTube channel called HoLEPverse. I've just started posting some videos online. I must say at this point I've been inspired greatly by Dr. Fernando Gomez Sancha after watching so many of his videos and performing so many of these HoLEP cases. I think I can, at this point in time, share my experience. And as I have benefited from watching a lot of similar videos online, I hope a lot of you find some use and benefit for this. So let's get into today's case. I have chosen this man who I recently performed the HoLEP for. He's a 120cc prostate who has been on a long-term catheter for a while, for a few months, and recently he's had few episodes of persistent hematuria which needed admissions, hemoglobin drops and blood transfusions, etc. So I had to take him up for an emergency HoLEP. And the reason why I chose this case to be my first video online was I wanted to actually showcase the benefits of doing an en-bloc HoLEP. So I always try and do an en-bloc approach with an early apical release. And as we go through the case, I think I will try and point out the advantages of doing an en-bloc surgery. And I think this case in particular highlights them. So yeah, as you can see, I always enter the urethra using a visual obturator. I use a 26 French laser resector scope sheet. My standard is I use, right now I'll be using a luminous high power machine with the Moses 1 technology. So in this case, as you can see, there's quite a bit of, there's brisk bleeding ongoing. There's some clots in the bladder as we enter. So I guess I'm trying to find my bearing at this point in time. Trying to see how severe the bleeding is at this point. And as you can see here, there's some contact bleeding here. Normally I wouldn't be too bothered by these sort of bleeders, but considering the case in question, I thought it would be a good idea to secure some hemostasis first before we start the enucleation per se. So yeah, I think hemostasis is a very important skill to have while performing holmium, and I think holmium hemostasis very well. I think the trick is to defocus, maintain a certain distance from the tissue. I think the settings may play a small role, but yeah, I do use settings of 1 joule and 40 hertz for hemostasis, and for enucleation I use 1.5 joules and 45 hertz. So yeah, you can see a nice big prostate, 120cc, obstructing lobes. You can see the left apical part of the prostate. There is a BPH nodule right there. The identification of the sphincter is very important, I think, and it's very easy. I think at all times, in all cases, you should be able to do it. So yeah, let's go right into the surgery. I'll talk a bit about the technique and the steps that I use. So once you come back, I think I was doing this case under spinal surgery, spinal anesthesia. So the patient was coughing about a bit, so I was trying to talking to him and then calm him down. So there you go. You can see the clear demarcation of the sphincter, and I'm creating the white line as Gomez Sangcha calls it. So as long as the vision is good, you'd want to make a distinct line that is between the sphincter and the prostate. The idea behind this, I think, is you want to be in control of where the sphincteric mucosa breaks, because the plane is where the plane is, and then you don't want an uncontrolled tearing of the sphincteric mucosa. So by doing this, we are preserving sphincteric mucosa and early continence post-operatively. So as you can see here, I'm trying to do a circumferential incision, and if the vision permits, I would probably deepen this white line, make a groove. That would be even better. It sort of sets you up for the initial part of the enucleation. So as we can see here, I'm deepening the white line to form a groove. Once that is done, you're quite happy with what you've done in terms of the white line. It's time to enter the plane. The easiest and the best place to do that would be adjacent to the veru montanum on either side. So this would usually always be my first step. Enter the plane with laser energy. As you can see, this case is just a lot of brisk bleeding. He has big vessels bleeding everywhere. So if vision tends to be a problem sometimes, you can use a gentle mechanical push like that, just laterally to see where the prostate peels. That usually shows you the plane. So you can see here very clearly where the plane is. You want to target the laser at that junction between the capsule and the prostate, and the distance of the laser fiber from the tissue also is very important. I always try and keep a millimeter or half a millimeter away from tissue, so you want the laser to do the work for you of splitting the tissue and splitting the planes. And while you're doing that, you're getting some hemostasis as well, what we call as first pass hemostasis. And if you did notice just now, I'm not too really concerned or bothered by the mucosal bleeding that is happening above me, because that part is going to go away once you get down into the plane. So once I have entered the plane on the right side, I'm going to do the same thing on the left side. I'm going to replicate this. The best part of this is you don't have to try too hard to find the plane, to be honest. As you approach the prostate from the apex, from behind, you will get into the plane very easily. You see what I just did there, and like Dr. Gomez Sanchez says, you will not always find the very beautiful plane. Like for example, on this side, you can see the capsule is probably not the very nice looking kind. So, but as long as you're on a capsular plane, so tissue identification and plane recognition is very important. If your tissue is turning brown with the effect from the laser, then you know it's still prostate, and you probably need to go one layer down or deeper. As what we're seeing now here, I think we're nicely on the capsular plane, developing the plane on this side. I tend to take this all the way up as much as I can, not causing too much traction on the sphincter. probably say around 4 o'clock on this side, and then say about 8 o'clock on the other side. Now, once this step is done, usually I will probably move on to joining these two planes in front of the Veru montanum to establish a posterior plane. So that will be the second step, or maybe the third step. The first step being the creation of the white line, the second step being entering the plane on either sides, and the third step being establishing the posterior plane by joining the two planes in front of the Veru. So this step I would probably do as much as I can, as much as it allows me, because most often than not you will find that you may not have leverage or space to get under the tissue, under the prostatic lobes. So do only as much as you can. Don't use too much of mechanical traction or force to do this. Allow the laser energy to do the work for you. So you can see here all this while quite a lot of brisk bleeding happening. Don't be too fazed by it. Just keep calm. Stay on this plane. You know you're on the plane. Stay on the plane. Make nice wide movements with the laser. You don't want to make short movements side and get into a tunnel of sorts, and then you're not doing much work. So you want to make large long incisions. That way you will release more of the prostate from the capsule, and then there'll be more space for the prostate to move about. Imagine you have an orange, right? You want to peel an orange all around circumferentially at the same time, and that will allow you to progress further. So I guess the aim is you want to progress towards the bladder at all times. So small steps at a consistent rate will get us there. But very important in such cases is again, make sure you're securing hemostasis as and when we are advancing. So if you notice, there have been these bleeders on the capsule itself, which those are the ones that I would pay attention to and control. So yeah, I think I'll persist a bit more. I was trying to persist a bit more with developing this posterior plane. So I think at this point maybe the patient was coughing again, or I was trying to get some vision back in. So one of the advantages of doing the on-block approach is you're irrigating such a small area, a very narrow field. You see, I'm only in this pouch of area, so whatever bleeding there is going to be washed out. Of course, you're going to have times when it's an arterial spurter and vision may be obscured then, but we'll probably come to that a bit later further on in the surgery. But basically what I want to say is one of the advantages of doing the on-block is you're not making incisions. Imagine this vascular and bloody prostate, and then we were going to do a two-lobe technique, making incisions. I would assume it would be a lot more bloodier, and vision probably not as good. So yeah, that's one of very crucial advantages I feel of doing an on-block approach. Yeah, there we have a arterial bleeder directly coming from the capsule. And then again, I think one of the techniques here to show defocus, stay away from the tissue, and hemostase. Once you have developed a sort of a reasonable amount on the posterior plane, I would eventually probably go upside down, get my laser at the 12 o'clock position, and then carry on with the remainder of the early apical release and release the anterior part of the tissue. Yeah, I think I was still trying to get some hemostasis secured here. Always a good idea before you proceed further. Make sure you have the best vision. It's always key. Sometimes bleeders may have vessels that may have retracted, as you could see here. So you need to expose the tissue around for you to be able to get down to the bleeder per se. So that's what we did just there. Yeah, and then still a bit of lot of generalized ooze or bleeding that I can see, and I think at this point, but reasonable vision. Pretty happy with it, and I think I've decided that I'm gonna go and do my next step, which is the early apical liberation part anteriorly. So the important points here would be, again, you want to release the distalmost part of the prostate, which is the apex near the sphincter. So you would have to make incisions, the initial incisions on the prostate, to release the tissue from the sphincter, as you can see over there, and always following the posterior plane. I'm taking it up laterally, or also something that I think Dr. Gomez Sangcha calls it mobilize and connect. So that is this part of the surgery where you're mobilizing the lateral plane and you're connecting it to the posterior plane. At the same time, you want to come back distally. You want to release the tissue. There we have that white line anteriorly. So I'm making incisions on the prostate, trying to follow the capsular plane, taking it upwards, up, and there we are at near the white line, where I'm just releasing it completely from the sphincteric mucosa. There. So take your time to do this, the early apical release. Don't rush into it, because this is one of the most crucial parts of the surgery, which really will set you up for the remainder of the surgery. Once this part is done, I usually think the remainder of the surgery is I wouldn't say a breeze, but yeah, it does make it much easier. So you can see here, I'm following that capsular plane. I think there was one part that was probably leading to a deeper plane on the lateral side. I corrected it. I recognized it early, and then I corrected my plane immediately. So that's another beautiful thing of using laser or a holmium laser. Allows you to do such things, correcting planes without or before too much damage is done. Yeah. So again, pulling back at all times, releasing the distalmost apical tissue that there is. Yeah, that's almost close to midline anteriorly. So I'm quite happy. I've released everything at the apex. I released the apex on the left side of the prostate. It's very tempting to, at this point, to just punch through and go all the way into bladder from there. But I don't want to do that because I haven't released the apex on the other side. I haven't released the apex anteriorly fully. So resist that urge. So you can see here, very nice sphincteric preservation on the left side of the patient. Now we're heading to the right side of the patient. Again, it's the same step. I'm going to be releasing tissue or cutting onto prostate at the apex to release it from the sphincteric mucosa. Sometimes you may not have this vision or you may have much more bleeding which may prevent you from doing the step, and in those cases I would probably develop more on the plane and then bring back your instruments to release the apex when it's safe to do so. So replicating the steps again on this side, as you can see there are bleeders all along, all as we progress through this case. So that is I think almost the 12 o'clock position there. So you see your plane is already established posteriorly, so you have a point of reference, which makes it very easy, and you're following the curvature of the apex. So I always think when you're doing this surgery, it's very, very important to, or at least I find it very useful to have a sort of a 3D map in your brain of the shape of the prostate, and then following small cues and signs as to how the prostate curvature is, and following that curvature and anticipating how the prostate is going to turn as you're advancing. That helps you stay on the capsule and in the plane. I do believe that. I think that helps me a lot. So again here, you can see I'm pulling back always to release the distalmost tissue anteriorly as we go up. You can see that I'm trying to go as anterior as I can, where I think the capsular plane is. I think we're there, which is quite nice, and then I think we're almost released the apex circumferentially. Again, the mobilize and connect part of the surgery, where you're connecting the posterior plane to the lateral plane, and yeah, you will encounter these big vessels and big arterial bleeders during the surgery. And I think what happened just here was, as I was trying to hemostase, and I think I broke the vessel in a place where it has led to a significant amount of bleeding, or a red out, if you may. So importantly, very important not to panic at this point in time. Just keep calm. Vision, if you're looking straight at the bleeder, you're not going to have vision. So the best thing to do is mobilize and release more tissue above and below the bleeder. Yeah, so that will expose the base of the bleeder, and you will be able to then hemostase it, which is what I'm doing here right now, as you can see. So I'm trying to mobilize below the bleeder, as much as I can. I will do that, and eventually we will get to the base of the bleeder, and we should be able to secure the hemostasis. So you see, the speed of movement also is very important. The distance of the laser fiber from the tissue, the speed at which you're moving, all these make a difference, and they eventually help in you progressing with the surgery faster. So I think I kind of got to the base of that bleeder, and I'm still trying to defocus and try and stop that bleeder as I can. There we are. And so you can see while I'm doing this, is sometimes the bleeder may retract again, and you kind of have to chase it of sorts, or you do the helicopters kind of movement to hemostase around the bleeder. So these are some of the tricks that you can use to tackle such significant and heavy bleeders during the surgery. Always take your time. Don't rush into, especially when the plane is nice, like now, and then the tissue is peeling very well. Don't get carried away. Make sure you secure a good hemostasis, because that'll pay dividends later on. So there's still something bleeding there, you see, and I'm trying to find it. Yeah, there we are. We see that, and you can see this I think is gonna retract back a bit, and then I have to keep chasing it. But take your time, and eventually these do stop. The laser is quite effective in these sort of settings because it is an end-on laser. So that's another point you should always remember. It's an end-on laser. You're not going to stop the bleeder by a side fire, or if you're not targeting the bleeder per se, then it's not going to work. So that's the other thing. Another point I wanted to say at this juncture is, you would have noticed I don't use an aiming beam or a guide light or pilot light. I find it distracting, and I find that can be glaring at times. So you actually don't need a pilot light when doing this surgery. It's not stone surgery where you maybe a pilot light would be useful, but I definitely don't find it as a hindrance during enucleation. Right, back to the enucleation after the hemostasis. So if you can see, I'm sort of again pulling back. I want to release the distalmost tissue. I'm trying to connect the lateral plane, and I'm now developing the anterior plane. I think this patient's planes were relatively quite nice now. I would say the tissues seem to be peeling quite nicely, and then the laser also is quite effective in this sort of recognition. Is definitely quite easy, I would say, for this patient. So you see, I'm trying to cross over near the midline. That would be the midline. You have the midline there, and I'm really right here below the sphincter. Probably the sphincter is just behind me, and I'm releasing the anterior tissue at the 12 o'clock position. And then once we have done this, we've sort of established the anterior plane completely. That's one of important steps during the surgery. Once you've done that, circumferentially you've sort of released everything from the apex, and you're free to advance, again, circumferentially all around. You want this orange to be peeled circumferentially, symmetrically. That would be the ideal scenario. You would notice me doing this all through the surgery. I'm always adjusting the laser fiber, the distance from the tissue, and then how I'm targeting it. I use an Olympus resectoscope sheet, coupled with, because that works, because I do have a Olympus Morsi scope as well, so that sort of fits nicely into the 26 French outer sheet, so I don't need to remove the outer sheet at the latter half of the surgery. Okay, so now I think we have nicely developed the anterior plane. We have connected the lateral plane on either side. You see there was a bleeder there, so I always find this, in most of the cases, I would say, usually things are symmetrical in the patient. So if you remember, we found a nice big bleeder on the other side around the same part of the prostate. So you can expect to find a similar sort of bleeder on the other side as well. So so now you can see once the apex is released, I've sort of sped up my movement, my speed of movement has sort of hastened. And also in this patient, the planes are very nice, so I'm trying to get along with the surgery, get a move on, make sure getting a good hemostasis at all times. In large prostates, at this point, again, you can get carried away. You can go straight, punch through into the bladder, but you would want to develop the plane more and more, both laterally and posteriorly as well. And always be cognizant of, again, the shape of the prostate. If you noticed at the beginning, a direction of the laser was always pointing outwards, and then mid-gland probably it sort of plateaued and we were straight on. But now you can see, as we're getting closer to the bladder neck, the prostate starts to close in, the planes begin to close in. So your direction of lasing would probably be more downwards all around, especially anteriorly. So you kind of take these cues, follow the shape of the prostate, and that way you will stay on the plane. And at this point, you would probably want to stay closer to the prostate rather than the capsule, to minimize the risk of causing any perforation. Although even if you do make a small sort of a deeper plane, very easily you can correct it immediately and prevent it from becoming a much larger hole. So I think at this point we're getting closer to the bladder neck. Once you start seeing more heavy bleeders anteriorly, you know that you're getting close to the bladder neck. Right. So at this point, I think it's more about connecting the dots, joining the lines. So I think there we are. You see, very typical and classical to find these significantly bigger vessels near the bladder neck. So again, always try and defocus. I think I was trying to get to the base of this bleeder. Holmium is an explosive energy, so the more you defocus, I think is sometimes better to control these sort of bleeders so that they don't retract back. You can see that I'm always trying to pull back my laser fiber more and more if the bleeding doesn't stop immediately. Yeah, there we go. Right. So I always again like to go back down to the posterior plane, develop it a bit more, take that laterally, sort of try and keep it symmetrical as much as possible. Sometimes you may have cross planes. It's important to maintain one single plane all around. So if you do have cross planes, join them, correct them early, so that you're not in a position where you're stuck or you're lost. Okay, so again, long incisions, repetitive sort of rhythmic motions, staying close to the prostate at this point in time. If you can see, capsules may be thin sometimes, so you want to stay closer to prostate. So I think here now you see, so at this point you see that the vertical fibers, very clear sign that you're going to be entering bladder now. And yeah, I think yeah, there we are. So we've entered bladder. Once you've entered bladder, your fluid dynamics change, and then if you don't have good hemostasis, things may get very murky very soon. So before you do this, just make sure you have good vision, your hemostasis is relatively good. Yeah, once I enter bladder, then I sort of follow the curvature of the bladder neck, which becomes quite obvious. Take that plane down on either side to 3 o'clock and 9 o'clock. Be careful of the ureteric orifices, obviously, as we go further down. And be cognizant of the planes here, because the prostate is falling away from you. You don't want to get carried away and go deep into the capsule at this point in time. So try and always avoid making perforations near the bladder neck, circumferentially even. Yeah. So at this point, I usually turn back my scope, get my laser back to the 6 o'clock position. I'm generally more comfortable doing this. I know a lot of other surgeons tend to keep the laser fiber at 12 o'clock all through till the end of enucleation, probably. I kind of find this easier. So at this point again, is about connecting dots, joining the planes. You have 2 points. You have a known plane, you have a known point A at the bladder neck, and as you come distally, you have your distal end of the distal margin of the enucleation. So point A and point B, you're kind of trying to join the two points while staying on the plane. Very important point at this juncture, you are below the prostate, so you're kind of lifting the prostate lobes up. So be aware that when you do that, you're also pulling the capsule towards you. So your aiming of the laser should be more towards the prostate again, because if you do aim at the capsule, then you risk perforating and then going deep. Another example of a bleeder here at the bladder neck can be quite common at this area. So I think we've made good time. We are still less than 40 minutes into the enucleation, and we're coming to the end of it. This is the last home run, I suppose. There we are. I think this bleeder took some time. Yep. I think this patient had really very nice planes. I must accept. So normally I wouldn't use a lot of mechanical dissection, but I think this patient's planes were so nice and his capsule was really well behaved, and I saw that his the prostate was enucleating really nice. So I think I decided to release all the medium lobe using mechanical dissection for him, as you can see here. Yeah, so there we are. So when you're doing this at this point in time especially, you're not really worried about causing too much strain on the sphincter because you've already released all the tissue from the sphincter. So none of this is being transmitted. I would warn you all to do of doing this maneuver in other cases or even routinely, because not all prostates are like this. Let me tell you, I think most prostates are not like this. I would still advise you to use I wouldn't advise you all to do this mechanical dissection in all cases, because let me tell you, it's not the planes are not this nice always. I would still using too much mechanical force may cause perforations, and then it may be very uncontrolled. So I wouldn't recommend doing that to all patients. Laser energy would still be safer, more controlled, aim more towards the prostate. So as you can see here, I'm dropping down the lobe at the bladder neck, taking the mucosa down, and basically repeating the same steps that I did on the other side. I usually like to develop this plane at the bladder neck. A lot of these large prostates have a subtrigonal extension of the median lobe, so you'd want to get into that plane of sorts at the bladder neck, so that when you want to flip the prostate over, it becomes much easier. You can see I'm staying closer to the prostate, allowing the laser to do the dissection for me. As you saw there was that extra layer. I think I'm trying to incorporate that into my enucleation plane, and join it to the capsular plane on the lateral side. So this sort of thing, very very common. You see that extra layer is what I'm talking about. Probably is the TZ and the capsular plane on the outside. So there we've joined that, and sort of very nicely peeling it off. The prostate is behaving very nicely at this point. So I think I decided, since it's peeling very nicely, I'll just go ahead and do this. And at this point, I'm using the same trick of trying to push the prostate into the bladder. So I would push the right lobe directed towards the left side of the bladder, and vice versa. So that way the entire bladder, the prostate, will flop back into the bladder. So that's what I've done here. So, and you have this tree trunk, what I call is a tree trunk, at the 6 o'clock position, so attached by the fibers. Make sure your UOs are far away. Crucial points at this step: stay within the bladder neck. I would advise stay within the bladder neck. Very easy to follow, you see, very easy to follow the prostate into the bladder. So, and when you do that, you may not even realize it, but you may end up being very close to the ureteric orifices, and you risk injuring the UOs at that point in time. So always pull back, stay within the bladder neck, stay within the bladder neck curvature at 6 o'clock. Okay, there we are, the UO is there. We're still some distance away, so I don't think I'm too worried about it. But you can see I'm still staying within the bladder neck. That would be the best and safest thing to do. And yeah, I think it's been barely 41, 42, 43 minutes, and we're done with the enucleation. So this, I wanted to keep it as an unedited video of the enucleation. I think for this patient, as you can see, nicely preserved sphincteric mucosa circumferentially. I think the focus is a bit off, and there we are, nicely preserved mucosa. And I think I'm changing instruments at this point. I generally don't use bipolar roller balls for hemostasis, but in large glands, in patients who who are on anticoagulation, and especially in a case like this, where we saw so much of large bleeders and a very large surface area, I don't hesitate to take out the rollerball and get a good hemostasis, because I think it's imperative to have good vision before you start morcellation. That's really the first step of morcellation, is really, I think, securing good vision and good hemostasis. So I don't hesitate to do this at all. I don't think it increases the risk of strictures in any way. I mean, people do bipolar enucleations, so I don't see how 5 minutes of a rollerball would increase the risk of causing strictures. In fact, I think it does add benefit to the patient. It would reduce the time of a washout or a catheter time, especially. So again, same principles as you would in any TURP. Do a systematic rollerball hemostasis starting from the bladder neck circumferentially and all the way through the entire fossa. So I think I'm gonna fast forward the video a bit over here and cut to the give you a brief video of the morcellation with a few tips on morcellation as well. All right, so changing instruments for the morcellation. This I do a quick change, so it's very, very important to have a good team working with you. I don't need to remove my outer sheet, so I do keep that inside. But what I do is before I remove my instruments, I sort of set up the morcoscope, which is basically I attach the camera, the light cable, set that up first, and then so the my nurse assisting me usually knows these steps. So it's very important to train the people who you're working with to ensure safe handling of instruments, to ensure who know exactly what they're doing, and then things like that. So it will be a quick change because I don't want to decompress the bladder too much, keep it filled. I use a single inlet irrigation. I know there are some people who use a double irrigation. I have never had to use it. I think I still get a good amount of distension with a single irrigation. My outlet is closed. Usually the bags are raised, and as you can see over here, I'm using a Hawk morcellator, which I think is a very good morcellator, very similar to the Wolf Piranha. I also use a drill cut from stores, which is I would say equally efficacious as a Hawk. I do like the Hawk a bit more because I think it's more controlled. I feel the suction to morcellation ratio is very well designed, and I find that the prostate does not jump off that easily, and it does feel a lot more controlled and safer, if I must say. So as you can see, very important, once you're in, you want to have the morcellator probe in the middle of the bladder with the prostate tissue above you. I generally use a bottom-up technique. I don't do a top-down technique that commonly, unless required. I think this was just some blood clots that was there from the beginning of the surgery. Yeah, so important steps during morcellation: make sure your irrigation bags are always there, being regularly changed. Don't let that empty out. No irrigation would mean you're sucking water and tissue, and then the bladder decompresses very quickly. And when that happens, it can be quite scary, and you don't want to be caught in that sort of a situation. very easily you would end up morcellating the bladder. So tissue in the middle, as Gomez Sancha would say, you want to see those two black triangles. But basically what it means is you want to see some black around your morcellator probe. And what that means is when you see black, basically your bladder is distended at all times. So and it's a good idea to probably start off at a slower rate in the beginning, get into a rhythm, and then you can always tailor your morcellation speed to how the tissue is responding. Different prostates are different consistency. Some are more fibrous than others. They tend to form more beach balls or mothballs or whatever you want to call them. I try and get the morcellation into the fossa whenever possible, or when the size of the tissue allows that to be done in the fossa. That would be the safest way to do it. So very calm procedure, I would say. I really enjoyed doing this surgery. In general, challenging ones are more fun. I think today's case was really nice in how it progressed in spite of the challenges we faced. As we all saw, quite a bloody prostate, but I think the end result was very satisfying. We managed to get about, I think it was 120 cc prostate, so managed to get about 94 grams of specimen, 43 minutes of enucleation, and 22 minutes of morcellation. And then so right at the end here you can see I brought the tissue into the fossa. Take your time, don't rush. The fossa can collapse on you as well sometimes. You don't want that thing to happen. So yeah, I think there we are, the last bit. Of tissue being morcellated, and as we can see, it's a very nice looking fossa, wide open, and we've stayed on capsule everywhere circumferentially, so no perforations is always good. That should be the aim. And I think this patient did well. See, nicely preserved sphincter as well. So we managed to remove his catheter on post-operative day 1. Patient has since been voiding very well without any incontinence. So there we are. And then I hope you'll enjoy the case. I certainly enjoyed doing it and doing this commentary as well. I hope to post more such cases in the near future. I hope you all have a good weekend ahead. Bye bye.